This is Dr. Caroline Peterson with Natural Women's Health Institute in Sarasota, Florida. Today I'm talking about pudendal neuralgia, which is sometimes called Alcock's syndrome. This is a source of pelvic pain, so it's part of our pelvic pain series. The pudendal nerve is part of the sacral nerve roots. It originates in S2, S3, S4. So you can see over here the green. Sacral nerve 2, 3, and 4 are the ones that almost always make up the pudendal nerve. Up here, we also have the sciatic nerve in yellow, L4, L5, S1, S2, S3. So there's a little bit of overlap between the sciatic nerve and the pudendal nerve as far as origin is concerned, and some of the pathway too. So the pudendal nerve is 30% autonomic, 50% motor, and 20% sensory. There are 4 smaller nerves that it breaks out into. The inferior anal nerve, which is sensory and motor, and that innervates the external and internal anal sphincters. The deep perineal nerve, which is motor only to the perineal muscles and the external urethral sphincter. We also have the superficial perineal nerve, which is sensory only to the scrotum, the labia minora, the vaginal vestibule, and the lower fifth of the vaginal canal, as well as the posterior aspect of the labia majora. And finally, the pudendal nerve includes the dorsal nerve, which is sensory to the external genitalia, including the penis and the clitoris. So this is the perineum, the external female genitalia. And so we have the dorsal nerve, which is going up to the clitoris, the superficial perineum. So it's in and out, in and out. No wonder it gets messed up. So here's another picture showing a little bit different perspective. Again, we have the nerve roots, S2, S3, S4. This here is the piriformis. And so you can see it comes in front of the piriformis, so inside of the pelvis. And then it goes outside of the pelvis behind the sacrospinous ligament right there by that ischial spine. And then it comes back in to the lesser sciatic foramina, and then into Alcock's canal, and then out to innervate the more superficial genitalia, so forth. It's a different one here, different pictures. Sometimes sit better with some people than others. So the greater sciatic foramina, the nerve roots, S2, S3, S4, become the pudendal nerve, goes out of the pelvis behind the sacrospinous ligament, back into the pelvis, into the lesser foramina, and then into that pudendal or Alcock's canal. So that's all the places that it can get stuck. So pudendal neuralgia is thought to be microtrauma to the pudendal nerve that causes pain in your bottom. This is historically particularly thought of as a tunnel syndrome, causing nerve entrapment. But now we see that oftentimes it's not really entrapped in a tunnel, and there can be other reasons for pain in the distribution of the pudendal nerve. So what it feels like is burning, tingling, stabbing, twitching in the external genitalia, the anus, the pelvic floor. You could have numbness. There can be sexual dysfunction, whether it's inability to sustain or get an erection, or difficulty with orgasm, or it can also be related to just having pain with sex. There can be sphincter dysfunction of the urethra or the anus, and sometimes people will have this sense of feeling like there's a foreign body inside of the vagina. One of the classical signs is that it's worse with sitting, unless you're sitting on the toilet, in which case it's not worse. And people generally basically don't have pain when they're sitting on the toilet with pudendal neuralgia. It should also improve with standing or lying down. Oftentimes it's unilateral, but there are cases, many cases also, where it's bilateral. Sometimes people will have buttock or even sciatic pain since it's so closely related to the sciatic nerve. Sometimes there can be suprapubic pain, pain above the pubic bone, kind of in the bladder region. Sometimes there can be medial thigh pain if the obturator nerve gets caught up in this. People will oftentimes have increased frequency of urination or even a painful bladder when the bladder's full. They also can have pain after sex or with ejaculation. And so pain after sex is going to be related to pelvic venous congestion. And so we want to start thinking like, what are things that are nerve? What are things that are artery? What are things that are vein? We want to start thinking through that. How does fascia involve? What about other systems? So we don't want to just think, oh, I have fascia that's constricting my nerve. We want to think, how does this present? What causes, what systems and irregularities cause these types of symptoms. So pudendal neuralgia is considered to be underdiagnosed, and so people don't really know how often it presents just because it's not thought of too often when people are working with pelvic pain. There's it's thought that about 1% of the general population have pudendal neuralgia, and that it could represent 4% of the people who have pelvic pain. Generally speaking, women are affected twice as often as men. However, with the cyclist, the males are affected more frequently. The most common reason that people get this pudendal nerve entrapment or pudendal neuralgia is with childbirth or any kind of surgery related to childbirth. It can be like an episiotomy or forceps or something like that. It can be pelvic prolapse surgeries that also can be related to pudendal neuralgia. Radiation for any of the pelvic organs, chronic constipation, repetitive activities like cycling or repetitive hip flexion, like climbing or jogging or sitting too much. Additional risk factors for pudendal neuralgia are endometriosis. So, I mean, you can think of it really like a space occupying lesion, right? Like something is taking up more space, so it's compressing the nerve. And so endometriosis will do that. It will take up more space. Viral infections create inflammation. They take up more space. Space occupying lesion, diabetes, that is going to be related to like the puffiness that you'll often see in diabetics as the body holds on to more water because there's so much sugar. And then there can be some dieback of the nerve, multiple sclerosis, also inflammatory condition, and people who do prolotherapy for pudendal neuralgia say that it's caused by pelvic instability. And so probably they're getting some good results that are helpful for people, although I was not able to identify anything in the literature that suggested that either pelvic instability was a cause of pudendal neuralgia, nor that prolotherapy was a helpful intervention. So it's probably something new that people have just started doing and haven't researched yet. So the standard for diagnosing pudendal neuralgia came out of France, and it's the Nantes criteria. They have inclusion and exclusion criteria. So if both the inclusion and exclusion criteria are met, then no further diagnostic imaging or anything is necessary. So for the inclusion criteria, the pain needs to correlate with the distribution of the pudendal nerve. That makes sense. The pain is primarily with sitting. The pain is not worse at night. There's no sensory loss, and the pudendal nerve block relieves the pain. Makes sense. The Nantes exclusion criteria are that you do not have pudendal neuralgia if you have pain someplace else where the pudendal nerve is not. That makes sense. If you have pain that include and itching, both pain and itching. If you have pain that is fleeting, it comes and goes. Or if you have imaging that tells you you have a problem somewhere else and not with the pudendal nerve. That makes sense. So less formal ways of diagnosing pudendal neuralgia are palpation. Can you reproduce the pain by palpating the pudendal nerve? Does the pudendal nerve block take away the pain? You could also do ultrasound or Doppler or MRI to see if you can identify any vascular or neurologic involvement in the pudendal neurovascular bundle. People who have pudendal neuralgia longstanding will have more difficulty with the warm sensory detection tests. It will take them longer. And the same with the pudendal nerve terminal motor testing. It will be more latent. It will take longer for the neuron to fire. So when we're looking at chronic pelvic pain and thinking, is this pudendal neuralgia? Is this something else? Is there an overlap? You know, the other sorts of pelvic pain include pelvic pain from endometriosis or adenomyosis, fibroids, musculoskeletal disorders, inflammatory disease, irritable bowel syndrome, painful bladder syndrome, and venous congestion syndrome, to name a few. So we want to think through those presentations, and those will be part of this chronic pelvic pain series. So the pudendal nerve can get entrapped in this greater sciatic notch here in the bottom, typically where the piriformis is, right? And then the sacrospinous ligament. It's most commonly squeezed between the sacrospinous ligament and the sacrotuberous ligament here at the ischial spine. It also can get caught up in that Alcock's canal here, or the terminal branches themselves can be squished. So I wanted to add this in about the sacrotuberous ligament, so that we're thinking, because it's easy to think, oh, pudendal nerve is in the pelvis. My problem is exclusively in the pelvis. But I want to show you, so right here, this is the sacrotuberous ligament. But can you see how it's connected to the whole body? And so it's contiguous and continuous with this lumbar aponeurosis here. And then it also is continuous with the biceps femoris of the hamstring. And so it's a part of this whole kinematic chain. And so it's not fair to just think of the pelvis as a standalone, because it's not. This is a French study of 100 pudendal neuralgia patients getting a gluteal flap surgery. And that is to try to take the pressure off of the nerve. So for them, they found that 95% of all the entrapment was there at the bottom of the greater sciatic foramina, and where the piriformis is, right by the sacrotuberous ligament, or between, they call it interligamentous claw. That's kind of cute, but we would say it's between the sacrospinous ligament and the sacrotuberous ligament, or in Alcock's canal. So those are the three places that almost everything in their study was trapped. The most common was being trapped between that ischial spine, at the ischial spine, between the sacrospinous and the sacrotuberous ligament, 74%. 40% were entrapped there at the bottom of Alcock's canal, where the sacrotuberous ligament has a little hook called the falciform process. And so in this study, they didn't tell us, what a success was. Like, they didn't give us they didn't operationalize their outcome measure. So who knows? But they said 70% had a significant reduction in pain. And that means that 30% had pain that persisted. So this is a picture of a cadaver. So right here, this is the sacrotuberous ligament that has been cut right here. They cut it off. So we can see behind it, right here, is the sacrospinous ligament. And on top of it is the pudendal nerve. And so this kind of is a good way of thinking about, how the pudendal nerve has to kind of go between the sacrotuberous ligament and the sacrospinous ligament, and how it makes sense that can be kind of like a narrow area. So 74% entrapment at the ischial spine in that French study. So that would be right here, where here's the sacrospinous ligament. The pudendal nerve goes out of the pelvis behind the sacrospinous ligament, comes back into the pelvis below the sacrospinous ligament, and that's the area where you have 74% of the entrapment in their study. This is transection of the body through the coronal plane, so sine you front to back. And so this is the rectum, the anus, this is your bottom, and this is your sits bone. And so right here is Alcock's canal. And so this right here is that little hook, that falciform process of the sacrotuberous ligament. And so this lower, very outside area was also one of the more common places, 40%, where the pudendal nerve was entrapped. Now, they also went through what their findings were. Like, what was the problem? What was creating the problem for the pudendal nerve? So in 27%, there was a narrowing or a stenosis of the pudendal nerve. 27%, there was a fibrous sheath around it. In 25%, there was a venous dilation of the pudendal vein. So we always have a neurovascular bundle, practically always. So we're going to have pudendal nerve, we're going to have pudendal artery, pudendal vein. So if they're traveling together and the vein is dilated, it's engorged, then that itself is going to put pressure on the nerve and create symptoms. 24% of the folks had inflamed fragile neurovascular bundle with bleeding. That doesn't sound good. 13% had too much fat around the nerve, and that was squishing into it. 3% had a flattened pudendal nerve. Now, this is a Brazilian study. This looked at 63 people who had either sciatic pain or pudendal pain for 5 years in general, overall, on average. These folks had had a prior surgery, and their pain persisted. And so these were the more difficult cases. So now they're going in for laparoscopic surgery. 1 year after surgery, 78% of these folks had at least 50% reduction in pain. And this study found that 38% of the folks in their study had a pudendal neuralgia that was of neurovascular origin, so more vascular stuff. 37% had endometriosis or origin. 10% had fibrosis origin. 10% had some kind of abnormal piriformis, so maybe the pudendal nerve was going through the piriformis in a weird way instead of in front of it. And 2% had a tumor. So the places, so again, this is not like an ideal study for looking at pudendal neuralgia because they combined sciatica and pudendal neuralgia. And so in a way it makes sense, in a way it doesn't make sense. Like we were talking about before, how there's some shared innervation of the nerve roots for the sciatic nerve and the pudendal nerve. So the place where they found entrapment in this Brazilian study, 35% was at S2, S3, S4 nerve roots. So further up than where we're generally looking for the entrapment. So right here, 35% nerve roots, S2, S3, S4. And so there's also the 25% also higher up at the sciatic or the lumbosacral juncture. So that's not going to be pudendal neuralgia. I mean, there's nothing lumbar that has to do with the pudendal nerve. So that's going to be the sciatic piece. And then we have 18% here at the proximal pudendal medial sciatic area. And then we have 12% at the S1, S2 nerve roots, which is probably going to be sciatic also. And then 8%, only 8% at Alcock's Canal. So this one very low. And who knows, they didn't report, you know, what surgeries people had previously. And so who knows, maybe they all had the Alcock's Canal surgery. Maybe they all had the sacrospinous, sacrotuberous ligament surgery. You know, who knows what they had before. And now, so this is very interesting to me, that we're seeing in both of these studies that there is a vascular component in a substantial number of pudendal neuralgia cases, and that this is generally underappreciated, not spoken of, and I would say unlikely that most people approach pudendal neuralgia with this possibility in mind. So in the French study, we see 25% of their patients had venous dilation, 24% of the patients had inflamed and fragile neural vascular bundles with bleeding. That's almost 50%. In the Brazilian study, we have 38% of the folks had a neurovascular component to their problem, and 37% of them actually had endometriosis, which was causing the pudendal neuralgia. So I want to show you here, this is the neurovascular bundle. So you got the pudendal nerve, artery, and vein. We have the pudendal nerve, internal pudendal artery, internal pudendal vein. So again, just looking at this neurovascular bundle, three things come together. This is again that coronal cut. There you're looking at the rectum, the anus, here's the sits bones, here's the pudendal Alcock's Canal, and there you have the neurovascular bundle. You have the pudendal nerve, pudendal artery, pudendal vein all together right there. So when I think about pudendal neuralgia presentation, then I'm thinking, you know, what does nerve do? What does vein do? What does artery do? How do they present? So pudendal neuralgia, when it's pure nerve, it should get better when you're standing, right? Because then you're taking the tension off the nerve. If there's kind of like a fascial constraint or something like that, that's causing the pain. But if your symptoms don't improve with standing, then what system generally is worse with standing? Oh, it's the venous system. The venous system is always worse with standing. And so then we're thinking, oh, maybe there's a venous component to this pudendal neuralgia, because this person is not better with standing. And so maybe pelvic congestion or something of that sort could be playing a role. We'll have to look into that. Also, if we see signs of any varicosities, if we see vulvar varicosities, upper thigh varicosities, abdominal varicosities, or superficial veins, which is what you'll see before you see varicosities, the blood is not going to be as backed up when you see superficial veins. And over time, they'll change from superficial veins into varicosities if the pressure system increases, which is to say that the drainage is poor. They can't get the blood out. Then we're thinking, oh, this is backed up veins, pelvic congestion, or congestion further up, where we're not getting the blood out of the pelvis, and this is irritating the heck out of the pudendal nerve. Is that going on? The other thing that you should be thinking of is, hey, if I've already had a bunch of fascial release, if I've had a standard decompression surgery, then maybe something else is involved. I want to rule out some of these other things like pelvic congestion playing a role in pudendal nerve pain. So I want to go over how the pelvis strains. This is the pelvis here. And there's several routes out of the pelvis. This is the vena cava. This is the inferior vena cava, abdominal vena cava. And it breaks off into the common iliac vein, which breaks off into the internal and external iliac vein. So the internal iliac vein is the one that's most responsible for draining the pelvis. The internal iliac vein right here. We also have the ovarian veins, which are secondarily responsible for draining the pelvis. We don't have it shown here. There's a superior rectal vein and a sacral vein that go into the inferior mesenteric vein. They're also responsible to a lesser degree for draining the pelvis. And then finally, we have this very interesting situation involving the pudendal vein, where there's actually drainage into the long saphenous, then the femoral, and then up into the external iliac vein. And so those are main drains out of the pelvis. So now we're going to go into those a little bit more. So why doesn't the pelvis drain? So these are kind of like diagnosable conditions that I'm talking about here. But before anything is diagnosable, you have a functional condition, which can still be highly problematic. And in natural medicine, we can treat it. We don't need it to get real bad before we can intervene. We can treat earlier. So that's good. So one of the things that can cause backup into the pelvis and cause pelvic congestion is May-Thurner syndrome. And that's when there's overlap and compression of the left common iliac artery over the vein. The artery always goes over the vein, but if there's compression, then that vein will not have the diameter that it needs to have in order to carry the blood out of the pelvis and up. So May-Thurner syndrome. I commonly find this, not the syndrome because I'm just doing it by palpation, but I'll commonly find that there's like a little knot there where there's like pulling and congestion. There's hard work in that area where the left common iliac vein is being compressed by the left common iliac artery. Another thing that you'll see is Nutcracker syndrome, which is when there's the renal vein is compressed, the left renal vein is compressed, and so then you get backup of the left ovarian vein. and into the pelvis. So you can have a straight up nutcracker syndrome, or you can have tension on the renal vein, and that not a straight up nutcracker syndrome, but there's enough tension in the system that you're not getting adequate drainage and you're getting backup. So you can get this with a ptosis or falling down of the left kidney that will compromise drainage of the left ovarian vein and back up the blood into the pelvis, or other things like that. So it doesn't have to be a full-on diagnosis. It can be still at a functional level, and give you plenty of problems to write home about. Also, a hysterectomy is going to make it harder to drain the pelvis in some cases because you're taking out some of the drainage system. An oophorectomy could remove even more of that drainage system, and compromise the ovarian vein itself. And so these are things. And then, you got to think about any kind of adhesions along the way. If you've had a cesarean, if you've had an appendectomy, if you've had gallbladder surgery, it could be a million things that it could be, chronic constipation. It could be any kind of gut inflammation that causes a lot of adhesions and makes it difficult to drain the pelvis. It could be a million different things. All of these things can cause backup into the pelvis, that make drainage difficult, and then irritate and annoy the heck out of that pudendal nerve. So the internal pudendal vein, remember, which is part of that, the neurovascular complex, it gets the blood from the inferior rectal vein, clitoral vein, posterior labial vein, the penile and scrotal veins, the anus, and the urogenital diaphragm. That's the one that drains into the internal iliac vein. So here we have the internal iliac vein, which is right here, coming off the common iliac vein. This is the vena cava. This is the external iliac vein. So here we have the internal pudendal vein right here, coming into the inferior gluteal vein and the internal iliac vein. Here's your piriformis, which is going through that superior sciatic foramen or foramen. You got your sacral spinous ligament, sacral tuberous ligament coming down. And so, yeah, so you got your pudendal nerve going through this area right here with that internal pudendal vein. The external pudendal vein is going to drain into the external iliac vein, and it receives blood from the clitoris, the labia, the penis, and the scrotum. And so it's the deep pudendal vein and the superficial pudendal vein that make up that external pudendal vein. So here we have the superficial external pudendal artery and vein. It's always artery and vein together, and mostly artery, vein, and nerve together before you break off into the little ones. The deep pudendal artery and vein, those go together into the external pudendal vein, which goes right here into the great saphenous vein, then up into the femoral vein, then up here into the external iliac vein. So the external pudendal veins are going to go into the saphenous, femoral, and then the external iliac. So this is the inguinal canal that it's going through. This inguinal ligament goes through the inguinal canal. So sometimes what you'll see is a backup of this superficial and inferior epigastric veins that can be related to the, it kind of can be a sign that something is going on with the pelvic veins, and particularly the pudendal veins. And so here Down here, we have the superficial epigastric vein and the inferior epigastric vein that come off of superior epigastric is coming off of that same great saphenous vein and femoral vein. So see, the pudendal veins are going in together with this superficial epigastric vein. And so if this one's plugged, because it's draining down like this into the saphenous vein and then up the femoral into the external iliac vein, that's saying maybe this is a plugged area right here. And that's why we can't get drainage out of the external genitalia. That's why we're having some pudendal neuralgia with sitting. The other thing with these that gives us a clue about if we're seeing varicosities or superficial veins with these superficial epigastric vein or the inferior epigastric vein is that they also anastomose here with the lateral thoracic and the internal thoracic vein. And so what'll happen is if there's any kind of, it doesn't have to be portal hypertension. It can just be a very stiff liver, a very inflamed liver that is not able to take all of the portal blood. Then what'll happen is that you'll have backup in these veins that then will cause too much of a load on that great saphenous femoral external iliac. And so the problem's not coming from low, the problem's actually coming from the liver that's not pulling its weight through the portal system and putting too much pressure on this this caval system, the vena cava. It's not able to pull up all the blood the way it's supposed to. So this is the vulvar veins here, the internal pudendal, which is part of the neurovascular bundle with the pudendal nerve, pudendal artery, going to the internal iliac. The perineal vein is going to go into that long saphenous vein. And then the external pudendal goes into the saphenofemoral juncture and then up into the external iliac. So people can have the vulvodynia, the painful vulva, for more than one reason with pudendal neuralgia. So again, the vulvar veins drain to the posterior labial vein, deep posterior veins of the clitoris, and the perineal vein are going to drain to the internal pudendal vein, and then the superficial external pudendal vein is going to drain the clitoris to the long saphenous vein. And then, of course, we can't forget about the lymphatics, because the lymphatics themselves, if there's lymphatic congestion, this can be another source of pressure on the nerve and cause pain. So all the lymphatics have to be drained too in order to optimize neurologic function. So this is the uterovaginal, at the bottom, it's the uterovaginal plexus that drains into the internal iliac vein. And so that also is draining the labia majora and minora. And so if you had a hysterectomy, part of that plexus could be missing. And so if there's something up higher where there's an incompetence, you may not be able to drain as well as you need to in order to avoid pain. So in biomedicine, their approach is to avoid painful activities, to get manual pelvic floor therapy, to do cognitive behavioral therapy, to take painkillers, muscles relaxers, things like that, maybe to use a TENS unit. The surgeries are, the decompression surgery that we talked about a little bit, the gluteal flap, the laparoscopic, those are the two more common ones nowadays. Also a pudendal nerve block, but those tend to wear off in being effective after a couple years. It's not like you can do them for life. And then there's a couple different ways that can be used to disrupt the nerve signaling and try to get less pain that way, kind of by tricking the body. And then some people are doing that prolotherapy, which seems like it hasn't really been researched much, and is supposed to be primarily related to helping instability. And so these would be like special cases that would need to be worked up. So when I looked at a meta-analysis of decompression surgery for the pudendal nerve, they described a successful surgery as one that improved, that gave a decrease of 30% in pain for 6 months. So that doesn't seem like a lot, but that was what they said success was. And so laparoscopic surgery performed the best. 82% of their folks had at least 30% improvement in pain for 6 months. The transgluteal decompression surgery performed at 75%. The transperineal surgery performed at 70%. And they didn't report on the transvaginal surgery. And I'm thinking that's probably because it's not done very often anymore. And I think it's more of an antiquated version of surgery, decompression surgery. So when I approach pudendal neuralgia, I'm really thinking of the whole body. I'm thinking of you as a complex person that lives in a moving environment and that needs to be able to be responsive to that environment and to all of your complexities. So part of what I do is going to be manual hands-on therapy. It's going to include pelvic floor therapy, intrapelvic care, but not just of the fascia, not just of the muscles. And that's not the first thing I do. I start by setting the body up so that it can receive change. So that usually means setting up the drainage system first. I work with the visceral system because the organs have to be moving properly in order for the vasculature to move properly. If there's vascular congestion, if there's venous congestion, then I work with the veins to help them be able to carry more blood. I work to get the blood out of the tissue, or the fluid, which would be the interstitial fluid, out of the tissue and back into circulation, which would be lymphatic circulation and some venous circulation. I do myofascial release, and then lymphatic drainage and chiropractic manipulation when appropriate. I work a lot with the posture, helping people come into a neutral posture, helping people properly engage the postural muscles and learn how to activate them in things like coughing, sneezing, things like that. We work a lot with the physiologic breath, since that's the pump of the body. And then I'll work a lot with plants, nutritional supplements for things like inflammation, the need for venous support, if there are adhesions. I also work with castor oil packs, things like that. So we want to set up the body to receive, optimize mobility. If you have a kidney that's fallen down or a uterus that's fallen down, that can really have an impact on the drainage of the pelvis. A uterus that's falling down, the cervix can even kind of influence the pudendal nerve directly. It can land on the pudendal nerve directly, and can have an impact on the pain. And so for that, it's very important to deal with that prolapse and stabilize it. And so that you really have a prolapse problem as the origin of your pudendal neuralgia. So you want to be thinking, oh, not just this nerve in isolation, but this nerve in relationship to the rest of its community. Of course, if there's fascial constraint, which there always will be, then you have to work with that. And then there'll be probably ligamentous and joint imbalances, working with those. And then, as I said before, the breathing mechanisms, the postural muscles, strengthening them and learning how to fire them correctly. That's my approach. I think that's it. Oh, nope, this is it. This is a overview. I always look at the 7 bodies and the 5 transverse planes. That's how I organize my mind around a person and what they're presenting with. So the body always guides intervention. And so we have these different bodies, and they'll speak up. They'll say, I need to be addressed first, me second. And so we'll follow the lead of the body. So we have the energy body, the emotional body, the air body, the fluid body, the visceral body, the musculoskeletal body, and the biochemical body. All of those could be involved to one degree or another with pudendal neuralgia. And then as far as the transverse planes are concerned, of course, everybody thinks about the pelvic diaphragm, respiratory diaphragm. We also have the thoracic outlet right here. We have the roof of the mouth, the base of the skull, the jaw as another transverse plane. And then right here, we have the sphenoid and the tentorium. All those transverse planes have to be lined up. They need to be parallel. And so we work with getting those parallel so that we have good information coming up and down between them. This is Dr. Caroline Peterson talking about Pudendal Neuralgia and Natural Women's Health Institute, Sarasota, Florida. Thank you.